The title of this talk is Access to Medical Care in Disabled Minority Populations. First, for some definitions, in the World Health Organization, the definition of health, it's a state of complete physical, mental, and social well-being. It's part of everyday life. It's really not the object of living, but part of it. It's considered a positive concept, emphasizing social and personal resources and physical capacities. Within that health definition, the term disability means the physical or mental impairment that limits one or more major life activities of that individual. There needs to be a record of the impairment. It's also being regarded as having that impairment. It's developed by the World Health Organization, the International Classification of Functioning and Disability. It provides a unified language and framework for the description of health. The ICF puts the notions of health and disability in a new light, bringing them both together. It acknowledges that every person can experience a decrease in their health and thereby experience some degree of disability at any time during their lifetime. And it mainstreams the experience of disability as a universal human experience. Within that definition of disability from the ICF, it serves as an umbrella for impairments, activity limitations, or participation restrictions. Impairments are problems in body function or structure that to some extent affect a person's ability to engage independently in some aspect of day-to-day life. This shifts the focus from cause to impact, so it's really goal-oriented, places the health conditions on equal footing, allowing them to be compared using a common metric. The ICF really tries to combine the medical and social models in order to provide a coherent view of health from a biological, social, and individual perspective. The ICF measures the impact of the environment on the person's functioning by documenting contextual or extrinsic factors. So who's disabled in the U.S., 54 million Americans, or 1 in 5 people are living with at least one disability. Most Americans will experience a disability at some time during the course of their lives. The most common description of disability are musculoskeletal or rheumatological, pain, but also certainly within the different disease types and structures, there are different disabilities. And so reality is every one of us at some point may experience a disability at some point in our life, whether it's from disease, pain, complication. Because of that, really there's this impetus to improve health and wellness of persons with disabilities. People with disabilities still have daily healthcare needs. These goals are to get and stay healthy. They need to be able to obtain the health care they need when they need it, just like everybody else. And people with disabilities need healthcare professionals who really understand and are able to communicate and respect them, not only as people, but also a person with a disability. So, and we need to be able to treat all their healthcare needs, not just their disability. So somebody who comes to a clinic with a disability still needs preventive care, still needs immunization, still needs surveillance medicine. So the goal is to change that, to improve that. Has to be an increase in understanding nationwide that people with disabilities lead normal, long, productive lives. Health professionals have to give the patients the tools to screen, diagnose, and treat the whole person with disability with dignity. There has to be increased awareness among people with disabilities of the steps they can take to develop and maintain a health lifestyle and a relationship with a medical care professional. And the accessibility to health care and supports needs to be improved. So as we talked, everybody has a potential to have some disability. People with disabilities have the same challenges as those that come with people that don't have disabilities for the health and well-being. Specifically, having the tools and knowledge and knowledgeable healthcare professionals to help them lead healthy lives. So what do they need? Within their structure of their life, they need accommodations and supports. They need access to health care. They need to be engaged in wellness activities. And they have to be able to get that supportive care from their friends and families as well. So when we look at quality of life measures, only 28.4% of people with disabilities report their health to be excellent or very good versus 60% of people without a disability. While disability doesn't really imply illness, some disabilities lower the threshold to an array of secondary conditions that can really negatively impact the quality of life. 87% of people with disability report at least one secondary condition, as opposed to 50% more or less of the people without a disability. So secondary conditions are physical, medical, and cognitive, emotional, or psychosocial consequences to which persons with disabilities are more susceptible by virtue of their underlying condition. And the secondary conditions can cause adverse outcomes in health, wellness, community participation, and quality of life. And the secondary condition can be varied. One of the more common is depression and fatigue, but certainly medical complications, hypertension, urinary tract infections, fractures, in particular in patients who don't walk, weight gain, skin issues, and respiratory problems, all can impact quality of life. A lot of these secondary conditions, particularly those acquired conditions, can be prevented with a combination of health maintenance practices, removal of environments and barriers, and improved access to effective medical care. But some others are inevitable and associated with the disease process, but may be able to manage, but not necessarily prevented and anticipated by medical care. Having said that, still there are many people with disabilities who consider themselves healthy and well, which enhances their quality of life. Maintenance of a healthy lifestyle enables people with disabilities to continue to learn, work, and live actively in their communities. Health risks and disparities associated with disability can make achieving a good health more difficult. So we want to obviously get rid of those as much as we can. So it really requires a provider who understands that people with disabilities can be healthy, active, and assertive participants in their management of their medical care. If they don't have sufficient knowledge and awareness of disability by the public, then healthcare and wellness service providers, educators, administrators, the media, and others, then that ability to communicate to the general public that people with disabilities can live normal lives suffers. There's much less ability to do that. And even within the population of people with disabilities, they find 25% of people found they had difficulty finding a doctor who really understand their disability. So as healthcare professionals and people who interface with people with disabilities, particularly from the medical care, really have to be able to respond not only to the disability but the whole person. And what's seen is when you don't respond to the whole person, you're just thinking about the disability, you're less likely to do things like preventive care. Terrible examples, 74% of women with disabilities greater than 18 report receiving a pap smear versus 78% of women without a disability. And then 55% of women with disabilities ages 40 and above report receiving a mammogram compared to 61% of women without a disability. So there's clearly a lack of basic preventive care in some of these patients. To compound the problem, in minority populations there's a lower amount of insured patients, and those are defined as they didn't have any private health insurance, Medicare, Medicaid, state children's health insurance programs, or state-sponsored programs to help with their cover their medical costs. Compared to non-disabled women, women with disabilities are among the most frequent consumers of medical services, despite that they get less preventive care. They're there more, but they're using the services for more non-medical services, Social Security benefits, wheelchair transport, and personnel assistance services, and the fact that you need medical certification for to be labeled as disabled. Lots of times within healthcare and wellness centers, so there just aren't the accessible services. Examples: women with disabilities that are wheelchair bound have trouble getting into obstetrics and gynecology clinics where they can be put on the table. There's no lifting help. So really, we need systems to make use of and enhance access. And it's not just medical care. Majority of surveys have been done of gyms and workout facilities where it's clearly obvious that they're not wheelchair accessible. So there, as we just said, the physical and architectural barriers are there, wheelchair accessibility, lifts. There are communication barriers for the hard of hearing, and there's attitude barriers of healthcare workers and the front office personnel. There are social and economic policy barriers. We talked about insurance coverage. So really, after understanding all those barriers, to set up an accessibility training program that then would help both the support staff and the professional staff. And obviously, the ADA requires accessible health care. There has to be reasonable accommodations, so changes that can be readily achievable and do not present an undue hardship on the facility. And that can be defined different ways. So sometimes if it is a hardship, it means that the building will not be accessible. And practitioners of facilities need to learn about and provide specific accommodations for people with a full range of disabilities, which can be onerous. But despite that, really, people with disabilities require the same quality of healthcare services and preventive care as any patient, but appear to be underserved and receive less than quality care. So when we define health as the absence of disability or chronic illness, it really negatively affects these people with disabilities. We really need to avoid stereotypes. People with disabilities can lead full and productive lives with high quality of life, sexual relationships, parenting, and be active in their communities. So really there has to be advanced access planning. So if for the case managers and the people trying to set up the care and the timing of these services, really have to listen to your patients and to your clients with disabilities to understand their background and their functional needs. Many people with disabilities really understand their disability and their needs, and they're experts in their own condition. And they'll tell you lots of times what they need and what they want. But you also have the flip side. People with a new onset disability really don't understand their disability, don't have that same expertise, and will require much more training to become more independent. So the model that accounts for the disability and a marginalized or minority constituency. So in fact, gender and race really have to be paid attention to. Within that model, they have to address a full range of barriers, including environmental, architectural, logistical, society, and cultural, really to impact the healthcare of the disabled individual as much as their biological impairment. And appropriate care at the onset of the disability can also prevent unnecessary hospital visits, mismanagement, and then ideally secondary conditions that can be prevented. Many times the team approach works best to accommodate the complex health needs. You see it's much more accessible in children's healthcare, where there'll be multi-specialty clinics, which are much more rare in adult healthcare. But even within that model, the primary care physician can act, or a case manager can act as a gatekeeper to prevent some unnecessary referral to specialists, and to make sure that all the caregivers are communicating with each other. So ahead of time, it's important to try to check accessibility when referring patients for a diagnostic study in specialty clinics, and making sure that not only they have the appropriate insurance coverage, but asking the questions: is your facility accessible? Can they get up on the examination table? Those kind of things. So really, you have to talk to the patient and your client, not the caretaker necessarily. You have to ask, how can I help you? Try to and respect that answer. Patients will and clients will tell you, if you ask them and you let them communicate what their needs are. Try to ensure that educational materials are accessible. Allow sufficient time for an exam. Many times with a patient with disability, it takes longer to perform a history and physical than somebody without a disability. And use people first language. Refer to the individual first rather than to disability. It's not uncommon to hear medical professionals say the CP kid or a CP child rather than a child with cerebral palsy. Some specific examples to disability sets. For the visually impaired, it's important to identify yourself and who else might be in the room with you when you walk into the exam room. You want to speak naturally in a conversational tone and speed. You can use words that refer to vision during the course of the conversation. And if you require somebody to guide somebody, you allow them to take your arm above the elbow and walk it in front of them. Never grab or push them. For the blind or visually impaired, you provide written material in auditory format on a computer disc in Braille or large print, possibly. For patients with hearing impairments, you ask them how to best communicate. From the onset, provide an interpreter, and particularly for important or medical issues, that interpreter probably should not be somebody who doesn't is not able to communicate in medical language. So the patients shouldn't be charged for their interpreter, and family members, children really shouldn't be pressured to interpret. You can provide written educational materials for them as well. You look at the person that you're speaking to rather than the interpreter, and don't block your face, particularly some of the patients who can lip read. And again, just like in visually impaired, speak using a natural conversational tone. For patients who are in a wheelchair, you try to place yourself at eye level, so you sit in front of the patient to facilitate conversations. It can be patronizing if you're tapping or patting patients who are below your eye level. You have to provide access to exam areas, as we talked about earlier, and provide assistance if necessary for a complete exam, even if it requires more time, which it will. Many patients and people in wheelchairs find it rude to be pushed in the chair, particularly if they don't ask for it. Sometimes they'll go to the point of taking off the push handles on the chair, and really try to have adjustable exam tables in your facility if possible. Patients with speech impairments, you want to be respectful. Never assume that the person has a cognitive disability just because she has a disability or difficulty speaking. It's very common to misjudge a person's intelligence based on their speech pattern or lack of. You want to listen when they're speaking. Many times they'll take longer to complete a sentence. You don't need to correct them, but you need to let them finish the sentence and try not to interrupt them. If you don't understand, don't pretend that you did. You want to ask them to repeat it or write it down before you respond. So questions for the caretakers and the patients themselves or case managers to ask. You want to know if the facility is accessible before you get there. Are the accessible entrances clearly marked? Are exam rooms accessible? Can you get a wheelchair in and out of a room? You want to know, make sure that, again, we cover all parts of a history, just like you would with an able body patient. You want to have them do a sexual history, which is typically neglected due to stereotypes. Are the medical and non-medical staff trained to be respectful and assist effectively? Is there adequate time within that schedule? A typical follow-up, 10 to 15 minute appointment may not be appropriate for a patient with a disability. It may require half an hour or 45 minutes for an appointment. Do they have telephones for communication relays and interpretation? Some resources for the patients and caregivers. The ADA, there's a family physician guide to culturally competent care, removing barriers to health care, tips and strategies to promote accessible communication, and then some other references. Thank you very much.